evening, everyone. I'm a last batsman with a very few score. I think so 1 or 2 run is remaining for winning. So I'm not that important. So thanks the chairperson to allow me to speak and my both friends who are there for me. So thank you very much. I'll make my talk very, very short. Yes, hats off to the audience. People are there. Pruritus vulva, which is given to me, which is one of the very common problem, less discussed. It's not seen here. It's less discussed, a very common problem in a female, and it is less addressed. Now coming to myself, I'm a gynae oncologist practicing in Ahmedabad. These are my areas of expert. Now vulva I considered as a no man's land because gynecologist doesn't want to come out of cervix and vagina and skin specialist doesn't want to go there. It is the most neglected organ of the body and the most common problem. So who owns the vulva? It has become like that. I think so as a gynecologist we have to look into the vulva. Recently, 2 decades, vulva has gained a very big momentum because of the cosmetic region. The northeast country like Thailand, there the men don't know the vulva has hair. Don't know the vulva has darker skin because of the Barbie vaginal doll. They want that type of vaginas and everything. And this is the wall of vulva. The cosmetic in Germany, he took the cast of female and there are 400 configuration of vulva. So this is gaining big momentum. And for that reason, many lesions are also coming up. For extreme ends, as an oncologist, what we see, vulval lesions, warts, malignancy, which is very dreadful. Pruritus vulva. What is pruritus? Itching over vulva. My topic is break the itch. How do we break? If I know the cause, I can break it. So it's common problem. Women will not go because they don't know how to describe. You ask any lay person, she doesn't know what is that. They will say it is a lip. They will say it is a part. They don't know how to describe. So these are the various presentations they come. In aged age, when we were discussing a previous session on sleep disturbance, one of the cause of sleep disturbance is dryness and vulval itching. It's a very common problem. So these are first we'll start with the common problem, which is a problem, candidiasis. Both the patients are candidiasis. This you see white discharge. It is a very common thing. We all know the treatment, but see on the opposite side. It is a lesions on the skin. And this is very infectious. These are known as tinea infection. Normal fluconazole will not work. And this is highly infectious. One in the family getting, whole family will get it. So you have to have these types of things. I will not go in treatment. There are chronic, recurrent, vulval vaginitis, how to treat, what are the diagnoses. These things I'm not discussing, but I'm only discussing what causes vulval itch. Jogger's itch, which is very common because of jogging, and especially in today's youngsters, they wear very tight-fitting clothes. So they are very, very common coming with vulval itch. I tell them at night, please wear loose clothes. Even they wear thighs and sleep, so these are all different things we should tell them. Common is red lesions of vulva, which occurs because of chronic irritations, and especially nowadays, the youngsters are now getting very much thing of vulval hygiene and vulval spa and everything, so they go for shaving, they go for laser, so they come with such type of itch and lesions. Warts, they don't cause itching, but they cause irregular type of lesions, and these lesions, if they get infected, they end up with leech. Herpes infection is very common, but for herpes, there is a burning pain. And coming now to white lesion of vulva, it is now recently divided into, vulval lesions are divided into 3 categories. One is white lesion, intraepithelial lesions, and Paget disease and melanoma. So these are white lesions, and it is a most worstful condition because what happens is a whitening at the vulval regions, and there are different type of white lesion. One is known as lichen sclerosis, hypoplastic, and mixed variety, and the skin becomes thick. This is a 8 hourglass type of appearance which comes, and it occurs in the aged group, and there is a stenosis of vulva, there is retention of urine, there is dyspareunia. So these are all different types of vulval, and what we do is vulvoscopy, and we should know the different part of vulva and how to examine. Vulvoscopy is a 3-ring method where you see the outer ring, the middle ring, the inner ring, and you find out the diagnosis. This is a abbreviation. This is a chart. How do you do the charting of the lesion? This is in the higher magnification. See, this is a white lesion of vulva. I want to take a biopsy, but I did a scopy. I saw abnormal area. So this way we can find out. There is a Toledin test to find out the abnormal area. I'm just running fast. This is the management. Apart from medical treatment, you have to have a lifestyle management. If there is too much itch, you have to tell them to put a cold pack, then give steroid therapy, and later in white lesion, there is no need of doing a surgical procedure, only if there is an VIN1. Now coming to pre-malignant lesions, which is known as vulval intraepithelial lesions. It is a now rising problem. And if you see, there is a new classification. Now it is divided not as VIN1, but as divided into L-cell and H-cell. And L-cell and H-cell, again it is divided in two parts. One is H-cell, which is usual type, which is seen in a younger woman, and that is due to HPV, and VIN, that is known as DVIN, which is non-HPV related. Vulval lesion, if you don't treat them, 80% will progress into malignancy. 80% will progress to malignancy. If it is treated, only 4% will go in malignancy. I am not discussing all this detail, but this is a case study I will show you. This woman had vulval discharge. She used to tell the gynec, she was from northeast, she couldn't speak proper Hindi. Khujli aa rahe, khujli discharge. The doctor gave a treatment. After that, she did a hysterectomy in this patient. Then also she had complained, then she was referred to me. You see, I did a vulvoscopy, and these are the lesions here. This is a patch here, this is a patch here. And when I took a biopsy, it came on VIN1. So I did vulvectomy. This is a 1 year after follow-up. So vulvar VIN is a surgical management as well as a medical management. We all know IMICO, mode treatment, podophylline, these are all medical management. This patient had white lesion of vulva, and we took a biopsy. It came of VIN1, so I did an excisional. I have not removed the whole white lesion, because if you remove it, 30% again will come. This was a patient which was HPV 16 positive, colposcopy scene 1. She had a white lesion on vulva, that also came out VIN1. I did a laser. This is the first time a laser was done. This was a patient with multiple warts. Sorry. And this was the wart which were removed. This was a patient which had a growth, and it came out to vulval incarcinoma in situ. So this is a different type of management. HPV DNA is advised, and in this patient, any VIN1, if you are treated, no carcinoma, in malignancy, no invasive, then definitely you can vaccinate them, because it's very, very effective management for prevention of invasive. Vulva is a region where the HPV clearance is very low. For cervix, the clearance is 80%, when vulva it is only 40%. HPV stays there. So to suppress that HPV, vaccination is very helpful. So this was a 26-year girl coming with warts. I did a vulval excision. HPV was negative. 3 months I called her follow-up. You see there is a lesion on the wall, on the forecheek. So she is now vaccinated. I'm going to biopsy her and treat her. So these are the different type of vulval lesion will come with the itch. There are preventive measures, and there is a vulval self-examination. You have to teach your patients how to do it. It is all available. So for me, I always tell my friends and everything, treat the patient, not the lesion. So this is very important. In the Paget disease, you will see they are coming with itching, and if you see such type of lesion, do a biopsy, send it to an oncologist, because it may have underlying adenocarcinoma. These are the different modalities available, and melanoma in situ, you can see such type of lesions. And lastly, vulval cancer, they come with itching and they come with growth, which is very common, and you need to have a surgery like this. This is my first HPV clinic, and this is my vulvoscopy, colposcopy clinic. This is Dr. Walter, who invented LEAP. He had visited my clinic. To summarize, vulval cancer should be prevented, and pruritus vulva is a very disturbing problem, difficult to treat. You have to identify, you have to address whether she has a discharge, whether she has a itch, and they don't know the anatomical part. You have to explain them, and the gynecologist should be aware of all lesions. Thank you very much.
Thank you very much for